So hi guys, I'm Danielle. I'll just be giving you a session today on how ECGs work and how to interpret them. Today, it's all aimed at preclinical students at the moment, but I know there's quite a lot attending who are clinical as well, so hopefully it'll be a good refresher. But we're going to go right down to the basics and talk about the foundation so everyone understands what's happening with ECGs and the electrophysiology of the heart, okay? Because that will help you identify pathologies even if you are later in your training. So today, we're going to talk about the normal ECG, how to perform an ECG, and calculating the rate, rhythm, and axis, and using all of this information to try and actually identify pathologies and look at the cases that we'll talk about tomorrow. So we'll start off by just clarifying something. Everyone's always talking about if a doctor gives you a 12-lead ECG, they're just like, oh, tell me what this says. By the end of the session, you should be able to identify what all these little squiggly lines actually mean. And when people say, here's a 12-lead ECG, what do they actually mean by leads? Well, leads, when you talk about it from a cardiovascular perspective, actually refers to different viewpoints of the heart. So you're looking at the heart from different perspectives, and the ECG is such an excellent tool to look at it from 12 different ways, and that way you can identify different pathologies. Now, the confusing thing is that when you're actually doing an ECG and performing it, those wires that you're actually using are also called leads. So everyone gets confused about when people are saying, oh, put the leads on in a cardiac arrest. Can you put the limb leads on? Can you put the chest leads on? Throughout this talk, I'm going to refer to those leads that you're actually physically, the long wires with the electrode on the end. I'm going to call them wires, and electrodes, which is the actual thing you're putting on the skin of the patient. And when I refer to leads, I'm going to be talking about the perspective and the viewpoint that you're looking at from the heart. Okay? So you have 12 leads in an ECG, 12 views, and you actually have 10 leads or 10 wires/electrodes that you're putting onto the patient physically. And we'll talk about this later, but I just wanted to clarify that at the start. So the important thing to start off is right down to the basics in terms of what an ECG is. An ECG is basically a graphical viewpoint of the electrical activity that is happening in the heart. Okay, and the way that this works is that the heart consists of many different small myocytes, which are basically cardiac muscles that can have some action potentials and that can have some electrical energy. Okay, so to understand how that activity corresponds to the physical thing that we see in the ECG, we need to understand a little bit about electrodes. So these things that are on your screen now, these are some cardiac myocytes, okay? And they have the ability to have an action potential and some electrical activity that can eventually lead to their contraction. We decide to put an electrode on one end. That's a negative electrode. That's one of the physical things that you as a doctor are putting onto the patient's skin, okay? We decide to put a positive electrode on the other end, okay? In order to formulate a lead, so a viewpoint, you need to have a negative electrode and a positive electrode. If the action potential or the actual energy is going towards the positive electrode, then what you'll get is a positive deflection on the ECG. That's all you need to understand. So electrodes can pick up positive deflections, meaning the energy and action potential is going towards them. Negative deflections, meaning the action potential is going away from them. Or they can be flat lines, or what we call isoelectric, when the action potential is actually perpendicular to them. So say we put another electrode down, that's a negative there, and we put another positive down. And this time the action potential is going away from them, the positive, okay? If you're going away from the positive, what will we expect? Just a negative electrode deflection, okay? That is the ultimate basics of those lines that you're seeing on all of the ECGs, okay? So if you see a positive deflection, that means whatever you're looking at, wherever you're looking at from the heart, that's where the action potential is going, okay? And then vice versa for the negative. That is really important to understand in terms of what we'll actually be looking at later on. Now, in order to understand what's actually happening in the heart, we need to have a bit of an idea about the actual anatomy. Now I'm looking at the heart here and I can see a sinoatrial node. Hopefully you can see my mouse. A sinoatrial node here, an atrioventricular node here. So this is all in the right atrium. And then you have these things called the bundle of His, which are just nerve fibers going down the heart. And they split into two things, the right bundle and the left bundle branch. Okay, I don't want you to remember anything about this anterior fascicle, posterior fascicle, that stuff's a bit advanced. Just remember that the bundle of His splits into two, the left and the right bundle branch, okay? And those things are what go and form the Purkinje fibers and actually depolarize the heart, okay? So what we'll start off with, we're going to decide to put a couple of electrodes on. And for the sake of this, just trust me, we're going to go with lead 2, okay? And it will all make sense later on in the talk. But we've decided to put a negative electrode up here and a positive electrode down here, okay? When, like I said, you have a negative electrode and a positive electrode, you form something called an axis. So lead 2's axis is going in this direction, okay? From negative to positive, okay? That is the axis of lead 2. Now, to actually work out what's happening when we're basically just looking at lead 2 now, just remember that. And this is basically the mean vector that goes towards the positive axis, okay? So we're going to start off with the action potential in the heart. Where does it all kick off? In the sinoatrial node, okay? So your sinoatrial node releases an action potential, and that goes all different directions in the right atrium, and eventually goes all the way down to the atrioventricular node here. Now, if you look at the mean vector, which is the total direction that this action potential is going, it's going from here to here, okay? If you look at that from an overall position in the axis of lead 2, so the direction, it's going completely towards the positive end, right? So if we have an action potential that's going towards the positive part of the lead, we're expecting a positive deflection, okay? That's what the P wave is. So the first thing you see when you look at an ECG, any lead on the ECG, any viewpoint, is a positive deflection, which should be your P wave if the patient has a regular and normal heart, okay? And this represents atrial depolarization. So when the sinoatrial node releases this a bit of electrical energy and it goes to the atrioventricular node, it causes the actual atrium to contract. And that's atrial depolarization. And you see that in the P wave, okay? This is important to understand because any issues with P waves in conditions like atrial fibrillation that some of you may know about, atrial enlargement, changes in the morphology of the P waves, you can now identify that something's going on in the conduction of the heart up here, right in the atrium, okay? And we'll continue to talk about that later and in tomorrow's session when we talk about pathologies and their causes. So, sinoatrial node, conduction, down to the AV node. What happens there is that there's a bit of a delay in the AV node now. So what happens is that your heart doesn't want to completely depolarize the ventricle straight away. It wants to have a bit of a delay to make sure that all the blood gets from the atrium to the ventricles in time, have a bit of a delay, and then causes the contraction, okay? This delay basically means that the electrical conduction is just chilling there in the AV node. It's not going anywhere. It's just staying there. So if the electrical potential is just staying in that one place, that means there's no overall vector. It's not going towards the positive end of the lead. It's not going towards the negative end of the lead. It's just staying there. So what do we expect? Nothing, just a straight line. And that's called the PR segment. And that is important as well, because if you know there's any lengthening or changes in the PR segment, you know there's a problem with the conduction going to the AV node. And what conditions are these important in? Things like your heart blocks, where you get lengthened PR segments. Things like your pre-excitation syndromes, which is quite advanced. But anything that's happening with the AV node, you get alterations in your PR segment. Normal PR interval, so that's your PR segment. PR interval is what we actually use clinically in order to determine how long your PR segment and your P wave is. So that should be less than 0.2 seconds. And that starts from the beginning of the P wave and goes all the way to the end of the PR segment. Okay, anything that lengthens that is a problem, and we'll get onto that. Now, what happens next? You've gone from your sinoatrial node, conduction's gone down to the AV node, conduction stayed there for about less than 0.2 seconds. Down the bundle of His is the conduction now, going all the way down, and it splits into two parts. your left bundle branch and your right bundle branch, just two bits of nerve fiber that are staying there, and they end up conducting the tissue. What happens here is that the first thing you need to depolarize is your intraventricular septum. So this bit that stays here. The part of the bundle branches that does this is the left bundle branch. And I just need you to remember that left bundle branch causes depolarization of the the intraventricular septum, okay? And the way it does this, you kind of, if you imagine the septum to be a bit here, because the left bundle branch is over here, the septum's a bit to its right. What happens is that you get conduction potential going from the left to the right and slightly upwards in comparison to when you look at the axis of this lead, okay? If you get action potential going away from the positive lead, okay, because we know it's not going left, which is where lead 2 is, the positive electrode of lead 2, it's going right, it's going away from there, and it's going slightly up, so actually closer to the negative electrode. That basically means that you're going to expect a negative deflection. By definition, the first negative deflection after the P wave is called a Q wave, okay? And officially that is what interventricular septal depolarization represents. Okay, and that's important because of what we'll talk about with the QRS complex in a second. So you've got your septum depolarized. Now what? Now basically we need to get the actual apex of the heart depolarized in order to actually contract, because we know the heart goes from contracting from the bottom of the ventricles, squeezes the blood, pumps it all the way out to the aorta and the pulmonary vessels, okay? So we got to start from the bottom. So what happens? We start over here. All the electrical potential is going down here all the way to these walls of the myocardium, okay? When all of the potential goes over there, you can kind of argue that there's no real direction to where this is going. What will the actual deflection look like on this actual ECG? What will the graphical representation of this depolarization be? You got to think of it in terms of what part of the heart is thicker and what part of the heart has the greater cardiac output. So we know that the left side of the heart is what provides blood to the whole body, okay? The right side goes to the lungs, the left side provides it to the whole body through the aorta. So in order to pump all of that blood all the way to the rest of the body, the left ventricle is very, very thick. So you have this sort of potential going to the right side. If we kind of calculate all of these separate little lines that we drew and make them one thing, that's kind of what it will look like for the right side, okay? The left side, since it's got to pump all of this blood all the way to the rest of the body, and it's so thick, you need to have a much greater magnitude of electrical potential to provide the same force, okay? To put it simply, you just need way more energy to do the same thing. So you have this massive magnitude of potential going to the left ventricle. Now, if you think of what the mean vector between these two things are, so basically where would the actual, if you incorporate both of these into the graphical representation of what the heart looks like here, usually you'd kind of go in the middle, but it's more leaning towards the left if you think about it, just because of how much energy you actually need to get the heart pumping from the left side. So you have a basic mean vector, or the main energy source, actually going to around here, if you think about it. And what is that? That is going towards the positive electrode. If something's going towards the positive electrode, which way is the deflection? Up. So that's where you get your massive R wave that you see on the ECG. That is ventricular apex depolarization, okay? And that's what you see in your QRS complex. Now, if there's a problem with this, we'll talk about that in a second. But the next thing we've got to think about is you've now depolarized the apex of your heart. You've got it to kind of almost pump from the bottom. What you need to do now is kind of get these ends of the heart to depolarize as well, the bases. So what happens? You've got your energy here, your electrical energy, your electrical action potential. It ends up going upwards towards the myocardium, all the way to the bases of the ventricles. When things go up this way, if you just think about it, which way is the direction of the action potential? Towards the positive electrode or towards the negative electrode? Towards the negative electrode. And if you think about it here, it's going towards the negative electrode. If things are going towards the negative electrode, Positive or negative deflection? Negative deflection. So the depolarization of the ventricular bases causes your S wave. Now, overall, what this complex is called is your QRS complex. And overall, it represents what we say ventricular depolarization. So that's what causes your ventricles to contract. A normal QRS is less than 0.12 seconds. This is very important because we're going to be talking about things like bundle branch blocks and other things that can basically broaden your QRS, and hypertrophies that can actually increase the magnitude of your QRS. And you can identify if you see any QRS problems on the ECG, you know there's a problem with ventricular depolarization. Okay. So the last things to consider. Now you've got the whole myocardium here with the ventricles depolarized. Okay. I've just put that with little pluses. That's all depolarized, but we haven't actually repolarized it yet. It's all contracted, all the blood's gone, but we haven't got it to repolarize yet. This time where we're just waiting on repolarization, you have your ST segment, you have another isoelectric line, pre-repolarization. We all know ST segment alterations happen in things like MIs, happen in things like ischemia, and that's all very complex maths and the reason why it goes up and down. But it's important to identify that when there's a problem with the pre-repolarization period, you have ST segment alterations. Now, when we want to actually repolarize the heart, you start at the base and all of these positives end up going to become negatives. So you have a negative charge that ends up going all the way up from the apex to the base on either side of the heart. Okay. When you have a negative potential that's going towards a negative electrode, you'd expect a positive deflection. So negative towards negative is positive. What we saw before was positive towards positive, and that was leading to a positive deflection. Okay, now you have a negative towards a negative. So you'd also get a positive deflection. Now, this is called the T wave, which is ventricular repolarization. Okay, any problems with the T wave are problems with repolarizing the ventricles. And that happens with things like electrolyte imbalances, like hyperkalemia, which we'll talk about. And it happens with drugs. Now, one thing that is important to know as well is the QT interval. That starts from where your Q wave starts all the way to the end of the T wave. And that happens in alterations when you get given things like antipsychotics and other antibiotics and medications like that, just for your reference for those interested and the more senior medical students. But by looking at all of that, that is essentially what your ECG is. So that is what the lines you're looking at. Normal QT interval, just for reference, is less than 450 milliseconds. Now, so you basically now understand, or you should hopefully have an idea of what those squiggles actually represent. Now, we know there's 12 of them, and those 12 things are viewpoints, are leads. How can we get 12 of them when we're actually just attaching 10 things to the body? Well, 3 of them are what we call bipolar limb leads. Okay, one of them is lead 2, which we were just looking at, which I'll come back to. The other 3 are what we call augmented limb leads, which we'll talk about as well. And then the last 6 are chest leads or precordial leads. Okay. So what actually are bipolar limb leads? Bipolar limb leads, if someone says to you in a cardiac arrest, hey doc, can you please put on the limb leads on this patient? And you're just a bit shook about, oh my God, what do I have to do? One thing you have to do is you just put the limb leads onto the arms and the legs. They're limb leads, right? Easy way to remember this is that they're color coded, and there's like mnemonics and things like that, like ride your green bike or read your green book, or there's different ways that people remember it. But that's kind of how you can actually start performing an ECG and putting your limb leads on, okay? But what we want to know is what actually are the limb leads and how they actually work. Now, the limb leads are important because you're looking at the heart from a viewpoint, from a vertical plane, from the frontal coronal plane. So imagine you've got this man here and you've just chopped him in half, all the way down from the head, all the way down to the feet, where you have an anterior section here, okay, and a posterior section. So you've just chopped him down like that, okay? Now you've put these electrodes and wires onto this person's body, okay? You've put them onto the red onto the right arm, the yellow onto the left arm, green onto the left leg, and then black onto the right leg. Black we ignore because it's a neutral lead, a neutral wire electrode. We ignore in terms of what we're about to talk about next. So this is basically what you've done. Your reds on your right, yellows on your left, greens on the left leg, okay? Now it's important to just understand leads, as I spoke about, the actual viewpoints of the heart are made with a positive and a negative electrode, which are what you just put on the patient's body. So let's say we put a negative electrode on the right arm with the red, okay? We've put one negative electrode. That wire you put has a negative component to it that you just put on the right arm, okay? And on the left arm, the wire you put on has a positive electrode component on, okay? You have just made one lead, one viewpoint of the heart. And the potential always goes, as we know, from the negative to the positive, okay? And we're going to call this lead 1. Now, it's really important to know when you're actually looking at the leads and what viewpoint I'm talking about. The viewpoint, your eye is always going to be where the positive electrode is, every time. And when I say your eye is going to be there, that means that is the part of the heart that you're going to be looking at when you look at the lead 1 strip on the ECG. So what do I mean by that? Well, if you imagine it here as well, this anatomically is the left side of the body. So if you're looking at lead 1 from over here where the electrode is, you're looking at the left lateral part of the heart, okay? And imagine it here. If you're looking at this person from this angle, you're looking at the left side of the heart. So when someone says you're looking at viewpoint of lead 1, you're looking at the left part, okay? Now imagine we put another electrode on, another negative onto the right arm, another positive onto the left leg. Action potential goes from negative to positive. We're going to call that lead 2. What does that represent? Where do we look at the heart from this viewpoint? Always from where the positive end is. So we're looking at lead 2 from the bottom of the heart, the inferior aspect of the heart. You're looking at lead 2 here. You're actually looking up towards the bottom and the base of the heart, okay? Let's do the same with the final lead. This thing that you put on the left arm has a negative component in its electrode. It has a positive component in the left leg. Where are we expecting the action potential to go? From the left arm, which is the negative, to the positive on the left leg. That represents lead 3, okay? Where do we look at the heart when we're looking at the viewpoint for lead 3? Your eye is always going to be where the positive electrode is. So again, you're looking at the inferior base of the heart. You're just looking at a different angle from lead 2. If you remember lead 2, we're like kind of looking this way. We're looking that way. Lead 3 is the same thing. You're looking at the bottom of the heart, just at a different angle. You're looking this way and you're looking this way, okay? The reason these are called bipolar limb leads is because you have these 2 electrodes that go from negative to positive. And those are the physical things that you're actually putting on the patient's body, okay? And the positive electrode is called the exploring lead because that's where your eye is actually looking at the viewpoint of the heart, okay? Now, you have these things called the augmented unipolar limb leads. These are basically loads of fancy math. Some guy called Wilson back in the day managed to make the ECG even more fancy by adding 3 more leads to it. And these are augmented limb leads because they work with just one electrode where there's a positive electrode. And the ECG itself basically puts these 2 other electrodes that are negative in their place. And I'll show you what I mean because it's a bit confusing. So say on the left arm and the left leg, you have 2 negative electrodes. That's what the ECG, the clever machines, put in place. You have a positive electrode in the right arm. Now we know that action potentials and the way you actually look at these leads always goes from negative to positive. But now we have 2 negatives. So what the hell are we actually going to do? Well, what's going to happen is that the ECG is a really clever piece of kit and it basically formulates an augmented lead. So it makes a vector between these 2 negatives all the way to the positive. And that basically means it looks at the middle of the 2 of them. So you're starting by looking in the middle of these two electrodes, going all the way to the positive one, okay? And what did we say about how we're actually viewing the heart from this aspect? Well, our eye is always where the positive electrode is. So when we're looking at this lead itself, we're looking this way towards the heart. And remember, anatomically, this is your right. And we basically have here an augmented unipolar limb lead looking at the right. But we're lazy and don't want to say that every time. So we've basically shortened it to AVR. Okay? Now, let's think of it with the other leads. Left leg, right arm, negative electrode components of the things that you actually put on the body. ECG's been really clever. There's also a positive on the left arm. ECG's been really clever and has made a vector between these negatives going towards the positive. Okay? That, your eye is over here, as we said, looking towards this way. Okay? What is this? Your anatomical left. So this is an augmented unipolar limb lead looking towards the left part of the heart. Okay? Last one. 2 negatives there, 1 positive on your left leg. Where's the action potential going to go? Between the negatives, the ECG is going to make a vector and make it go towards the positive. Where is your eye going to be looking at this viewpoint of the heart? It's going to be looking up. Oops. Yeah, it's going to be looking up. So it's looking this way. This is an augmented limb lead of the foot, AVF. So we've basically talked about all of the limb leads now. We know that leads 2 and 3 are looking up, and leads 1 are looking from the base. Lead 1 is looking from the left in terms of the bipolars. In terms of your unipolars, we know that AVR is looking from the right, AVL is looking from the left, and AVF is looking from the bottom, inferiorly. And some of you may see where I'm going with this. Okay, but we'll come back to that. Now, this is what a lot of people get confused about when it comes to actually working out axis and axis deviation. Each of these leads has their own axis, as we already spoke about. So lead 1's axis is this way, lead 2's axis is this, AVL's axis is this. But I just want, and we'll talk about axis a bit later about how to actually calculate it. But I just want to emphasize that we've basically explained how we make this diagram. So if you look at the augmented limb leads, AVR is going this way, AVL is going this way, AVF is going this way, AVR is going this way, AVL is going this way, AVF is going this way. They've just superimposed it on this diagram. We know that lead 1 goes from here all the way to the left side because we're looking to the left. We know that lead 2 goes from here all the way to the bottom and we're looking inferiorly. But where's our triangle? Well, we just got to remember that that triangle's still there, and this is called Einthoven's triangle. This is lead 3. Lead 3 is going from here all the way down and we're looking up. But the only difference here is that they've just translated lead 3 over here just to make the circle look a bit nicer. But otherwise, that's exactly what we've talked about in terms of the viewpoints of the heart, if that makes sense. Now we've talked about the limb leads. Remember, we're looking at the patient vertically from that. The chest leads or the precordial leads is when you split the patient in half, just slice them across the body like this, transverse horizontal plane, okay? And you're looking at the chest leads from a physical, actually through the chest wall position, okay? And initially, we're going to start off by just talking about how to actually place the leads on the chest. And if you're asked to put the chest leads on, what are you going to do? Basically, find the jugular notch and then find the angle of Louis, okay, which is another notch just on your sternum. And you could try this on yourself right now. This corresponds to the second rib. Space underneath that, second intercostal space. Space underneath that is the third intercostal space. Space underneath that is the fourth intercostal space. So on the right side of your sternum, that's where you're going to put V1, fourth intercostal space, right side of the sternum. V2, same thing, just on the other side, on the left side of the sternum, fourth intercostal space. The next lead you're going to put on is V4. So you look across the mid-clavicular line all the way down to V5, to the fifth intercostal space. And that's where you put V4. And then you just chuck in another electrode in the middle, which we call V3. Then in the mid-axillary line, you check the fifth intercostal space and put your V6 electrode there, and then chuck in another electrode in the middle of that, which is V5. Okay, so that's how you physically put these electrodes on the patient. And remember, you're looking at the heart from through the chest wall, through a transverse plane. Okay, so another view of the heart. When we actually look at this, so when we're actually looking at how we're looking at the heart, because we know how to put the ECG on now, that's not a big deal. When you're actually looking at the heart, we want to see what we're actually looking at, okay? So over here, these are basically the 6 chest leads. And you can kind of see what part of the heart is best viewed from each of the leads, okay? So for example, you look at lead 1, V1 and V2, which you put here. You're kind of looking very well at the septum. That's really close to here. And you can argue you could see a bit of the back of the heart, the posterior aspect, very well here. If you compare it to V6, there's all this tissue in the way. You can barely see the septum. It's not that clear. V1, it's not that deep. There's just a bit of right ventricle in the way. V3, V4, right next to the apex, nice. See the anterior aspect. V5, V6, completely on the left side of the heart. You see all of this thick left ventricle, okay? Ignore this. This is Wilson's central terminal. It's basically an advanced concept talking about where the energy is actually coming from and where you can see it in the heart. We don't care about that. We're doctors, we're not physicists. So what we care about is actually what we're looking at and what part of the heart we're looking at when we're actually looking at these leads. And just for reference, the cool thing about chest leads is you don't need to worry about this positive, negative electrode business. Any electrical activity that happens through the chest wall, these electrodes pick up on. And they're all positive electrodes. So as we know, any energy that's going towards a positive electrode has a positive deflection, and vice versa. So I think you know where I'm going with this. We already know that leads 1 leads AVL, and now we know V5 and V6 have a really nice view of what the heart looks like on the left lateral part. Leads 2, leads 3, and lead AVF can see the bottom of the heart. The chest leads can't do that because remember, we're looking at it from a transverse plane. Leads 2, 3, AVF are looking at it from the bottom in the vertical plane, the inferior part of the heart. And then leads V1 to V4 have a really nice view through the chest wall of the anterior and the septal parts of the heart, okay? These are what we call contiguous leads, and everyone bangs on about this because it's so important in order to actually isolate and identify where the pathology is coming from. And the really cool thing is, coincidentally, each of these territories that people talk about are actually supplied by their own coronary artery. So just a quick revision on the coronary vasculature. You have your right coronary artery, which supplies the bottom of the heart. So the inferior leads have a good view of that. Your left coronary artery splits into your left circumflex, which supplies the left side of the heart, the lateral part, 1 AVL, V5, V6. And it also splits into your left anterior descending, which looks at the anterior septal part of the heart. Okay, so if you have an MI, you get ST elevation or ST depression. You can tell which artery it's coming from based on which leads are actually showing the abnormality on the ECG. And that's why it's really important to know that. So we've gone through what an ECG actually looks like in terms of what these waves represent. We know that this P wave represents a bit of atrial depolarization. We know that the PR segment is while the action potential is going to the AV node and it's just staying in the AV node a bit. QRS complex, big ventricular dipole. ST segment, waiting for repolarization. T wave, complete repolarization. Have a good look at this ECG, because this is the perfect normal ECG. And some of you who maybe are more astute may say, oh, Daniel, look at this. You've got an ECG which has some inverted T waves in AVR. But just to remember, AVR is looking at the heart from which part perspective? The right. And we already said AVR, the reason it's not really circled here is that it's kind of a sideman lead. We don't really care about it that much because it's looking at the right part of the heart, okay? It's not that important, especially at preclinical level. So if it's on the right part of the heart, That's where the positive electrode for AVR sits. What is the T wave? The T wave is the repolarization, the negative charge that's going away from the apex of the heart. So it's going right and it's going up. So it's going right towards where the positive electrode in AVR sits. So you're having a negative charge go to a positive electrode. That causes a negative deflection, because we know a negative charge towards a negative electrode would be a positive deflection. Positive charge towards a positive electrode would be a positive deflection. Anything that is negative towards positive or positive towards negative would cause a negative deflection. So a negative inverted T wave in AVR and also in V1 occasionally is considered normal, okay? So this is your normal ECG. So let's learn how to actually present these, and actually what are you looking for when you're actually looking at an ECG. So the main thing is you want to look at the patient's details, date and time of the ECG, and they're all written at the top. So those aren't that bad. You want to check if the ECG is actually calibrated. So the normal calibration for an ECG is 25 millimeters per second in terms of the amplitude, in terms of the rate, and 10 millimeters, which equals 1 millivolt on amplitude. And they all just sound like random numbers. But a cool thing is that you always see these random boxes in the beginning of ECGs, and no one ever tells you, but this is basically what you use to judge the calibration. So in your exams or in your OSCEs or whatever, if you actually point that out, people will be really impressed. So each of these little boxes are 1 millimeter. So this like big box thing here, if it completes 10 of those little boxes, then the ECG is standardly calibrated. That's just a note. But then we get to the real crunch and what we're actually looking for when we talk about ECGs. So you want to calculate the rate, which we'll talk about, rhythm, axis. And now you kind of know what axis is, basically the direction the lead is going. But when someone says to calculate the axis of an overall ECG, they're basically talking about what is the overall mean vector of the action potential in the heart as a whole. So not one viewpoint, what we're looking at. Where is the actual electrical current in the heart going from when it goes from the sinoatrial node all the way down to the apex of the heart and back? Which direction is that going? Is there something blocking it? Is there something in the way? Has the heart been deviated slightly for any reason? Is there an ischemic event that's caused us to not be able to have some energy in one part of the heart? So that's all what the overall axis deviation is looking at. Then you look at the ECG systematically. So you look at your P waves and your eyes go straight to the rhythm strip. Okay, you look at your P waves, you look at your PR interval, QRS complexes, ST segment, T waves, QT interval, and then you summarize your findings. And we'll go through this all individually. Okay. So this is the ECG we just saw, okay? No tricks here. What is the rate? You can calculate rate in a couple of ways. One way is by using the number 300 and dividing it by the number of big squares between each QRS complex on the ECG. So between two QRS complex, I should say, sorry. So for example, if we're looking at these two, just count the number of squares. So that's 1, 2, 3, 4. Okay, and a bit, you can see this, so almost 4.5, you'd say, okay. 300 divided by 4.5, about 70, okay. And you can eventually, with practice, you don't have to remember your like 300 times table or your divisions. You just know 300 divided by 1 that, 300 divided by 2 is this, and you kind of pick it up as you go along. So 300 divided by 4/300 divided by 5, you know the heart rate's going to be somewhere between 60 and 75. And we don't need an exact number. The whole point of the heart rate, and clinically what you're looking at, is to see how fast the patient's going or how slow the patient's going. So you want to know if the heart rate is going bradycardic, meaning if it's less than 60 beats per minute, so very slow. You want to know if the ventricular rate is normal, so if a patient's normal cardiac, which is 60 to 100. If the patient's tachycardic, if that's 100 plus, and within tachycardia, you want to know how fast it's going. So if the patient's going 110, 120, it could just be that a physiological response. They might be doing exercise, who knows? If the patient's going 150, 160, 200, you know pathologically something's wrong with the patient there. So the whole point of rate is that it's a ballpark figure that you want to try and get hold of, all right? The other way to calculate rate would be to count the total number of QRS complexes in 10 seconds, which if the ECG is well calibrated, you just look at the rhythm strip and just count. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and you multiply that by 6. Because this is 10 seconds, you want a minute. 6 times 10 is 60 seconds. So you times this by 6. So 12 times 6, 72. You get a pretty much almost exact answer with both. And like I said, you don't need an exact answer. This is all for a ballpark figure so we can work out what's going on with the patient clinically, okay? And just side note, you should always use ECGs in conjunction with clinical history. If someone hands you an ECG and just says, read it to me, you might be able to identify some alterations with the wiggles and the lines, but until you correlate it with the patient's bloods and the actual history, you don't know what's going on. But in terms of rate, this is how you calculate the rate. And I think most people are okay with this. Now, rhythm is a bit hit and miss. The definition of normal sinus rhythm is when every P wave is followed by a QRS complex. So in this ECG, P wave, QRS, P wave, QRS, P wave, QRS. This is normal sinus rhythm. When someone gets, and the way you calculate whether it's regular is just by looking at the gaps between the QRS complexes. So if they're about the same, then calm, that's normal regular sinus rhythm, okay? Many of you may be able to recognize this is atrial fibrillation. Firstly, you don't really see any obvious P waves because your atria are producing electrical currents all over, not using the sinoatrial node. And now we know that the sinoatrial node's the thing that causes the P waves to come because your electrical potential is released from there, goes to the AV node, and that's how you get your depolarization. But in atrial fibrillation, your sinoatrial node's not really used, and you're getting little currents and little potentials all over the atria, and they're basically shaking like this, fibrillating. There's no obvious P waves, but that's not even the point of this. The point of this is that in atrial fibrillation, your ECG rhythm strip is irregularly irregular, meaning that the gaps between the QRS complexes are wide, short, wide, short, short, wide. There's no pattern, it just varies. And the reason it's irregularly irregular is that this isn't even a sinus rhythm, okay? There's no P waves. You physically, by definition, can't call something sinus rhythm unless there's P waves present, always followed by a QRS complex. When something's regularly irregular, on the other hand, you have P waves, P wave, P wave, P wave, P wave. That's followed by QRS, 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 QRS. But then something happens. So this, I'll give some of you guys a minute to think about the diagnosis. But in terms of being regularly irregular, the actual spaces between the QRS complexes are about the same, and then something happens. This is heart block. What type? We'll talk about it in our next session, but just for those who are curious and the clinical students, this is second degree Mobitz type 1, okay? Because you see the P wave, PR segment, P wave, PR segment's getting a bit longer, bam, you lose a QRS. So this is regularly irregular, and we'll talk about the pathologies next time, but this is what you're looking for in the rhythm. So as soon as after you do your patient details, date of birth, etc., calibration, rate, I want you to go straight to the rhythm strip and calculate your rate from there, look at your rhythm from there. And then the next step is what everyone hates, but after today, hopefully you'll have a bit of a better idea, is axis. So remember this graph I showed you earlier. You don't have to remember it every single time, but I want you to understand why it's there and how axis actually corresponds to this graph, okay? The way we look at axis is by looking at the vertical leads, i.e. the limb leads. If you remember, it's taken in the coronal plane. You split your body in half like this, okay? That's how you look at it. So 1 all the way to AVF is what you look at for axis, nothing else, nothing more. What we're gonna do is start off by looking at lead 1. What you do is look at the QRS complexes when calculating axis. Your QRS complex, you want to check if it's a mainly positive deflection or if it's primarily a negative deflection. Here, there is a clear positive deflection overall in the QRS complex, agreed? It's quite obvious, that's like a big rise. So what you mean there is that the electrical potential is going towards lead 1 this way. This is the positive electrode for lead 1, remember? It's going this way. We don't know if it's exactly here, or if it's exactly here, or if it's exactly here. All we know is that it's definitely not this way, anywhere here, because if it was over here, towards AVR, towards 180, towards 120, then that would actually be a negative deflection you'd see here. So what we can do, we can just get rid of that. We know that the overall axis is nothing to do with that. We know it's somewhere over here, okay? But we still haven't isolated where exactly the axis is going. Look at lead 2 next. That is a huge positive deflection. That can't be going anywhere away from lead 2. That's going to be going somewhere close to lead 2. So lead 2 is going this way. We know it's going to be somewhere on this 180-degree semicircle to lead 2, because we know it's going towards lead 2. It won't be going anywhere opposite lead 2 there. So we'll get rid of that. We know it's nowhere near there. So we already know the axis is kind of normal, but just to prove a point, look at lead 3. Positive deflection, again, another positive. Lead 3 is going this way, 120 degrees. We know that the axis won't be anywhere opposite lead 3. So on this semicircle, more than 180 degrees away from here. So we'll get rid of that. So by looking at those leads, we've already isolated where the overall action potential of the heart is traveling. It's going into this small area here. And it doesn't matter the exact degrees, who cares? As an F1, as a doctor, you're going to just be looking at the main pathologies and seeing what's going on and correlating it to clinical conditions. We don't need to be electrophysiologists and find out exactly how many degrees. You just need a ballpark figure like you did for the rate, like you've got for the rhythm. You just need a ballpark area that the axis is going to, okay? And just to prove a point, if you want, let's look at AVF, another positive deflection, okay? A massive positive deflection. AVF, where's it going? Down here. That means it's not going to be here because that will cause a negative deflection. Let's get rid of that, which we'd already gotten rid of anyway. So we know that the axis on this ECG is normal just by cutting out where it won't be and using an exclusion sort of system, okay? And if you want, I haven't got a box for this, but if you look at AVR, that is negative. AVR is this way. So if it's negative, we know it's not going to be in this part of the semicircle, because if it was, that would be positive. So we know it's going to be here. So it will basically, we've isolated it all the way down here. And we know this ECG has a normal axis. I hope that makes sense from using Einthoven's triangle and this weird circle thing that you see everywhere. That's kind of how you use axis. But basically, if you spend 20 minutes looking at the axis during the ward round, when someone hands you an ECG, you look as in that's not right? You need to find a quicker way to do it. So I've got a little trick that I think a lot of people use, which is an easy way to calculate axis, but now you understand, you'll know where it's coming from. And that's basically, I just look at 2 leads. In day-to-day, as an F1, you'll see tens of ECGs per day, and you'll have to be able to triage them to see which ones are important to raise to your seniors and which ones aren't. What you do is you look at lead 1 and lead 3, and you basically check what the QRS complexes are doing in those 2 leads. So if they're going up or if they're going down in terms of the deflection. So let's look at this ECG. Lead 1 has a positive deflection. Lead 3 has a negative deflection. These leads, QRS complexes, are leaving each other, you could say. They're facing away from each other. They're leaving each other. L for left axis deviation. Simple. And you can take your time and correlate it all the way to this graph. And I promise you it all makes sense. Because if lead 1 is positive, you know it's somewhere on this half. If lead 3 is negative, then you know it's somewhere on this half. So you know it's somewhere here, basically. Left axis deviation. 1 is negative. 3 is positive, heavily positive. These QRS complexes are reaching each other. L for leaving left axis, R for reaching right axis. Again, if you look at lead 1, if it's a negative deflection, it's going to be on this half of the circle. So we know it's somewhere here. If it's lead 3 and it's positive, we know it's going to be on this half of the circle. So we already know it's going to be here. And we've got our ballpark area and we've identified where the axis is going. So that is quite an easy way when you're on the ward run, when you're an F1, to actually calculate axis without having to draw this big circle thing. And it's really quick and it helps loads. So again, we're back to the normal ECG. if we look at this ECG, you may be asked to present something like this on the ward round. And what you'll do after you've calculated your rate, rhythm, and axis, you're going to have to look at the P wave, PR interval, QRS complexes, any ST elevation or depression, and then the T waves, and see how it's going from there. And you basically just cast an eye over all the leads, and you start off with the rhythm strip always. And then you go systematically. I start off by looking at the limb leads. Okay, they're nice in order. Okay, look up and down, just view any abnormalities when you're looking at all of that. Then you go through the precordial leads. Okay, let's have a look through there. Let's see how the chest is doing from a transverse view. Okay, now just to summarize, at the end you'd be asked to summarize the whole ECG. So I'll just demonstrate this for one example. Okay, so if we're using this ECG, this is a 12-lead ECG of patient X with the date of birth and patient details of whatever, taken at today's date at this time. Is calibrated to the appropriate standard, starting with the rate as a rate of approximately 70 beats per minute with a normal sinus rhythm and a normal axis with no axis deviation present. Going through the ECG systematically, P waves are present with normal morphology throughout the ECG. PR segment and PR interval is not lengthened and is consistent throughout the ECG. QRS complexes are narrow throughout with normal amplitude. There is no ST segment elevation or depression in any of the contiguous leads. T waves are present with normal morphology throughout, and QT interval is not prolonged. In summary, this is a normal ECG of this patient. And that's basically how you do a formal presentation in your OSCEs or your PACEs of how to actually present an ECG. Now, thank you very much for listening. That concludes this session. And I think we've talked mainly about what's been normal for the ECG, what you're actually looking at in terms of the axis, and hopefully you understand what these little squiggles and lines represent. Now you actually know that the ECG is a really good tool and a really good kit to actually look at the heart from different viewpoints and to actually identify what pathologies you're actually looking at. So I hope that was a bit useful. And then tomorrow, now we know what normal looks like, we're going to look at some problems and some cases, and it will be a bit more interactive with a Mentimeter, hopefully, if I can get it working. And we'll see from there. So thank you very much for listening, and I'll pass it back on to Ria or the BIMA committee.
Thank you so much, Daniel, for taking the time to do this session. We've just got a few questions that people have asked from the chat box.
Of course, yeah, go for it.
So, there's one question here that asks, can you explain the perpendicular electrode?
Sure. So in terms of when I was mentioning the perpendicular electrode, or I should say not electrode, it's more, wait, can you still see my slides? Let me just bring it back. So when it comes to something perpendicular, as we know from this slide,
sorry, Daniel, I don't think we can see the slides.
Oh, that's okay. I'll just explain it. When it comes to something perpendicular, so if we know there's a positive action potential going towards something, going towards a positive electrode, we know it's going to have an upward deflection. Yeah, does that make sense? If there's an action potential going away from a positive electrode, we know that's a negative deflection. Yeah. If something is going perpendicular to the positive electrode, meaning it's not going positively, not going towards rather, and not going away from that electrode, it would basically not be a positive or negative deflection. It would just be a straight line. So if you've got an action potential going perpendicular to the lead axis you're looking at, you basically have an isoelectric straight line. So I hope that makes a bit of sense.
The next question here says, do we need to know about bi and trifascicular block?
So it depends what level you're at, and I guess what uni you're at as well. I know at Imperial finals, you needed to know about trifascicular block and things. This whole series, I think, is primarily targeted at preclinical students. So tomorrow, I won't talk about bi or trifascicular blocks, but these are all kind of things that stem from heart blocks anyway. So if you understand the pathology and the pathophysiology of how heart blocks work, and now you know that PR segment and PR interval lengthening is all related to that, then you can kind of work your way towards tri and bifascicular blocks as well. In terms of whether you need to know or not, I think that depends on your own syllabus.
Yeah. And also there's a question here asking, why is there a little positive deflection in the S wave?
A little positive deflection in the S wave. Do you mean afterwards when you're going back to the isoelectric line? I'm not sure what I understand from that question.
Yeah.
So I'll try and explain what the QRS complex is. So you've got the Q wave, which we know is interventricular septal depolarization, which we explained because it's starting from the left bundle and it's depolarizing away from the electrode. So you get a bit of a negative deflection. Your R wave, big positive deflection because you have your massive left ventricular and right ventricular depolarization. And then you have your S wave, which is your complete, when you're actually trying to depolarize the actual bases of the ventricles, they're all going away from the positive electrode, if that makes sense. After that, when your S wave goes back to the isoelectric line, that's because your heart and myocardium is all completely depolarized, but has not reached the repolarization yet. So there's no actual vector potential going anywhere. It's just sitting there waiting to be repolarized. So there's no actual movement of action potential. So that's why it goes back to the isoelectric point, just completely in the middle. It's not quite like another positive deflection. It's just going back to where it was. If I understood your question, sorry if I didn't.
And here it asks, do all electrodes have a positive and negative component?
So when we talk about electrodes, the physical things that you're putting on a patient's body, the ECG is very clever where the physical thing you're putting on the wires, the ECG actually, I don't know about the physics in terms of what's actually on those things, but the ECG is a machine that basically can make those either positive or negative. And it's getting complex in terms of looking at the components of what's in the electrodes, like the actual engineering behind it. But not necessarily all of them have a positive and negative aspect. It just depends on what lead you're actually using and looking at. In terms of electrophysiology of the heart, in order to formulate a lead or a viewpoint, especially if you're looking at the bipolar or the unipolar leads, then you need a positive and a negative for the bipolar. And for the unipolar, you need a positive and then an augmented negative, which was kind of the vector that was in the middle of the two negative leads. The precordial leads are a bit simpler where they just work on with a positive lead electrode.
Yeah. And for axis deviation, does it matter whether you look at leads 2 or 2 when compared to 1?
So the thing is, you can look at any of the leads, like we said. Now you understand what that circle thing represents. You can use any of the limb leads to actually determine the axis of the heart and the overall axis. It's just whatever you prefer. So I like 1 and 3 just because they're almost opposite each other and perpendicular. Some people like 1 and AVF because they are actually perpendicular to each other. You can look at 2 if you like, but you'll need to look at lead. Like you can't look at 2 and 3, for example, because they're both looking at the, remember we look from that positive electrode. They're both looking from the actual positive electrode, which is the inferior aspect of the heart. So you can't actually rule out some of the deviation at the top. So you'd need to look at lead 1 and then something else like 3 or AVF. That's really how you'd look at it.
Yeah. And finally, there's a question here asking, is axis deviation just the electrical activity direction, or is it that the actual heart is slightly rotated?
So yeah, for the whole of med school, I was like, oh, the heart's probably rotated. But then you think like, why the hell would it just randomly move from its normal position? And then you realize it's actually the direction of electrical energy and direction of it in total going in the heart. So if it's going from the sinoatrial node all the way down to the apex, it's not actually the heart rotating, although that does play a part. So for example, in some conditions, you can have the heart completely like rotated the other way around and that would affect axis. But for just simplicity's sake, it's the actual potential of the heart in the direction. So if you have problems like a Mundell branch block or an MI that's affecting ththese nerves and Purkinje fibers that can affect conduction, that will affect axis deviation. The heart stayed in the same place, but the electrical potential has actually gone to a different direction if you think about it. So if it would be going this way normally, but it's blocked, it will now go this way just because it can't get to this aspect. So your axis and your electrical potential has actually deviated. It's not the heart moving, although that does play a part.